Okay, good morning, or afternoon, I'm sorry. I'd like to call to order the Board of Managers meeting. It is now 1:05 p.m., Thursday, July 29th. Today I'll be acting as chair as DT is not present. I'd like to go ahead and we'll start with opening the prayer and pledge. Angela, if you'd please come up.
Good afternoon, everyone.
Good afternoon.
Let us pray. Gracious God, as we gather in service to JPS and the communities that depend on us, we pause to seek wisdom beyond our own, trusting that it will guide our decisions. Help us remain united in our commitment to excellence, accountability, and care for others. Help us to make thoughtful, people-centered decisions. And may our work today strengthen JPS and reaffirm our commitment to improving the health and well-being of the communities that we are so privileged to serve. Amen. Please stand with me for the pledge. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Okay, thank you, Angela. All right, item number 3, we have citizens wishing to address the board. Today we've got 3 guest speakers registered, and we are going to have our first speaker up. The topic is Starved for Care Project, and Nan Terry, if you could please come up to the podium. Thank you, Nan.
Good afternoon. Thank you for allowing me to speak today. I'm Nan Terry, the Jail Action Team Lead for the Justice Network of Tarrant County. The Yale Investigative Lab began its Starving for Care series last year. If you Google Starved for Care, one word, you'll find the initial series. Now I'm going to quote from it. People are starving to death in local jails across the U.S. Who is dying and why? Unfortunately for Tarrant County, Georgia Baldwin was featured in the initial series, and she died while in custody waiting for a bed in the state hospital. The county paid $750,000 to settle a lawsuit brought by her family. She died of dehydration. Yet Kimberly Phillips died later of dehydration and starvation. And everyone should have a copy of the zine. That's what, I'm old, but this is called the zine. And Yale Investigative Reporter had this published. It's in conjunction with KERA. And this zine spotlights Kimberly Phillips. It's a part of the second series. Zines are created for some, but not for all. I actually think it did a really good job at humanizing the people who are starving for care. We want you as appointed board members to be aware of the issue of people starving for care, dying of dehydration or starvation in our county jail, but also in county jails across the country. We don't want to be a part of this national trend. We want you to advocate for responsible care of detainees in our jail. Let's stop this pattern. The zine mentions others besides Kimberly Phillips and Georgia Baldwin, and we realize that care is provided by a 3-legged stool, staff from JPS, MHMR, and the Sheriff's Office, but each group must do their part and work together. We don't need any more people dying of starvation or dehydration in our county jail. It should be all hands on deck to stop this. Please do your part. Thank you.
Thank you, Nan. Okay, we appreciate that. We have our second registered speaker today. The topic is healthcare issues within the jail. Harriet, if you could please come to the podium, and the timer will begin when you're ready.
Thank you. When I see 4 deaths in the jail in 11 days and read reviews of inmates starving or dying of dehydration, the glaring question for me is why? I believe that you're as distressed about this as we are, So what is happening inside the jail that keeps health care delivery from being what it needs to be to prevent these? We are here to say that if JPS can help us understand the barriers, we will do all that we can to help you eliminate them. For several years, I was concerned about the lack of clear accountability required of the sheriff's office and jail personnel, and was shocked that there was no formal agreement. There is now an interlocal agreement, but that agreement concerns me. It carefully defines what JPS must do after it becomes aware of a medical need. It says much less about the sheriff's equally critical responsibility to ensure that JPS becomes aware of the need in the first place. You can tell me if that really is the problem in the jail, but it appears that there is a huge gap there. This interlocal agreement ends on September 30th. I strongly urge you to review it and strengthen it before you renew it. At a minimum, it should include a section on jail officer responsibilities. For instance, mandatory referral obligations for detention officers, medical trigger criteria, custody notification timelines, officer training by JPS, joint quality review, and shared performance measures, the most basic requirement for improved performance. The ILA now includes very little requiring active participation, partnership, or accountability by jail officers to ensure good health care for inmates. It did not require any change from the circumstances under which 72 people died. And frankly, that leaves JPS vulnerable to bearing the blame for negative outcomes caused by failures outside your control. I have brought for you some suggestions to add to that ILA. These come from me Googling to find best practices. Your staff is the medical expert. But my field is organizational effectiveness, and I can confidently tell you that without shared standards, measures, and accountability, nothing will change. I hope that you see a critical need to improve this interlocal agreement, to strengthen your partnership with the jail before another preventable death occurs. Thank you.
Thank you. Okay, we're on to our third registered speaker. Topic pertains to in-custody deaths over the past month. Lon Burnham, please come up to the podium, and the timer will begin when you're ready.
Good afternoon. My name is Lon Burnham, and I've had the pleasure of meeting many of you in my capacity as I served 18 years in the Texas legislature, representing Central City, Fort Worth, and specifically the area you are here. And I was always a big supporter of JPS in my capacity in the legislature. First, I want to thank both Dorothy DuBose and Blake Woodard for being so helpful yesterday in coaching me on the do's and don'ts. This is my first JPS board meeting, and I wasn't quite sure how to approach you guys. But I'm here primarily to sympathize and empathize with your staff and team, because it is beginning to look like you guys get the near-death people in the jail on a last-minute basis where there's no hope of saving their lives. I think it's incumbent on JPS to look into the 4 most recent deaths, all of which have occurred in the last month, and see what things can be done to enhance the possibilities of getting them before they're near death. It is beginning to look to many of us that the jailers are simply dumping these near-death people on your ER. You are getting really unfair reputation because it's not deserved that you're being blamed for this. I only have one idea to address this problem other than enhancing communications with the jailers who don't seem to care about a lot of the people, as you've heard from the other 2 speakers, and what their situation is. Maybe JPS should insist that the jailers either do their jobs correctly or develop a rotation system where the other hospitals in the area get to share the burden of receiving the near-death inmates. You're simply not being treated fairly. The inmates aren't being treated fairly. There's a lot of things that have been suggested over the last 3 or 4 years to reduce the death rate in our county jail, but certainly transferring the near dead to JPS is not addressing the problem. It's just adding to the frustration that a lot of people, particularly the family members of the people that have died, are experiencing. Thank you for listening.
Thank you. Okay, no further citizens wishing to address the board. We are on to the approval of minutes. Item A is to approve the Board of Managers meeting minutes from June 11th, 2026. If I could get a motion, I've got a first, got a second, all in favor? Any opposed? Okay, the motion carries. As far as item 5, the board chair report, as I stated earlier, I am the acting chair for DT. In his absence, I don't have much to report on today. We did have a good meeting on the master's facility plan, and everything seems to be moving forward as planned, timing and budget, so far so good. We appreciate those updates this morning. But with that being said, I'm going to pass this on to our CEO, Dr. Karen Duncan.
Thank you, Mr. Chair.
Let's get now.
Oh, we're going to start by having Blake maybe tell us a little bit about the tour that you and Chuck took over at our jail.
Yes, so a few weeks ago on a Friday, Chuck and I toured the Tarrant County Jail's healthcare facilities led by Dr. Lowry and Chief Hairplots, who's on the right there, who runs the jail. We spent 2 hours reviewing all of the services and the active facilities that JPS has for healthcare in the jail. And then afterward, we spent a half hour with Sheriff Waver talking about healthcare issues in the jail. It was a highly informative tour. The first time that I toured the jail many years ago was when I was a member of the Leadership for Work, and Harriet Harrell was running Leadership for Work at the time. So this is 25 years later, but this was totally healthcare focused tour. And Dr. Lawley is open and available to tour the rest of you through the jail. Just reach out to her and schedule a time, and it will be worth every minute. You'll learn a lot about we hear a lot about the jail. You'll learn a lot about our services.
Thank you very much. It is a great team over there, and it is really eye-opening to take that tour there. So, thank you. Okay. So today I wanted to use this time to share a patient story that reflects the role JPS plays in trauma care for this region. It speaks to the expertise, the coordination, and the compassion required when a patient experiences a life-threatening injury. You're about to hear the story of a young woman whose life changed in an instant after a devastating motor vehicle crash last summer. Her journey illustrates the value of a strong regional trauma center and the critical role JPS plays within it as the region's longest-standing Level 1 trauma center. It also reflects the many people involved in her care, from the first responders and referring providers who stabilized and transferred her, to the trauma, the surgical teams, even to the parking attendant who greeted her family every day. As you watch, you will see the impact of trauma care for patients and families across our region. With that, I'd like to share Miley's story.
So June 25th, we woke up and Miley, she was driving to Santa Ana, Texas, where we're all from, and had a summer job spraying brush over there with a friend of ours, and was actually sitting out here on the porch drinking coffee and watching redbirds when I got the phone call that she'd been in an accident.
I don't even remember waking up that morning. So I ran into back
of like a dump truck looking thing. I don't know if it was a dump truck, I don't really know. But my car went under it, and not just into it, like under it. And so I ended up with this big gash on my head.
Meeting them initially, there was an increased level of just kind of needing to get everything right for her. She suffered pretty complex craniofacial injuries.
There was just like so many little parts of like my face that were broken, and like my head. My eye was dislocated, and so like there's just like a bunch of things like added up.
When you're critically injured in multiple organ systems, a level 1 trauma center is required to have all of the resources that are required to take care of a patient like Miley.
JPS offers state-of-the-art care. And in Miley's case, we took full advantage of the instrumentation we have available.
It was just amazing. Everything they did for me was amazing. All the nurses were amazing, and like my surgeon praying with me before my surgery, like that was like the biggest peace like I've ever felt, because like I'm fixing to have a major surgery and my surgeon asks like, can I pray over you? And him just going about it that way just gave me so much peace that like I'm gonna be okay.
They were very patient with the process and very hopeful people, and that always helps too, to have engaged family members, hopeful patients, hopeful families, and yeah, just a positive environment to help the patient recover in is good.
I have been trying to convince Dad to get a tattoo with me for, he promised me that we would get one if we made it back to the state basketball tournament. And he was like, only if it means something, only if it means something. And the day that I woke up, they saw 2 redbirds in Fort Worth. And like, that's crazy. Like in the middle of Fort Worth, why would there be redbirds out there? And so it really meant something. So we all got matching redbird tattoos. But that's my take on the redbirds.
I don't know, that morning they took her off her breathing vent and everything, and like, she gonna be okay.
I knew that like I woke up for a reason, and like I was still there for a reason, and so like at that point, like thinking like there's nothing else to be afraid of.
This was the bow that the nurse gave her to go with her pink hair, and so I said, that's not going anywhere, that's staying here with us. And so we kept her bow and her pillow that even some of the doctors had signed. It was really special.
I like lost all my muscle. I think I lost like over 20 pounds in the hospital, and so like I could barely like stand up for minutes at a time just because like I had nothing to hold myself up. But I kind of just like had the mindset during my recovery, like I can do it, and like I'm gonna try to build my leg muscles back up so I can go on sunset walks with my friends again. If I want to get better, and if I want to like be able to have a future I want to have, like I'm gonna take it little steps at a time to not just sit in what happened, but like to make myself better because of what happened. And so
Most of the recovery that takes place in a critically ill patient is taken on by the patient and their family. How well she recovered speaks volumes in regards to her grit and determination and the support she had from her family. But from our standpoints, I think it represents the teamwork.
I just started painting like mats, like welcome mats. So like this is like a Tarleton one for one of the ladies here that used to be a Purple Poo, and then like this is one of my favorites because it's just like so fun. And
When you pull off stuff like that, it's not one person, it's a team of people. And you know, from the lady that in the parking garage that greeted me in the morning to the folks at the little coffee shop that took time to speak to me, you know, and just the nurses and doctors that cared.
I'm just so grateful for JPS and everything they did for me, and they saved my life.
Yeah, it's stories like this that really ground us as to who we are. This thing brings tears to my eyes, but it really grounds who we are and is the reason why we're here. And
That young lady, her soon-to-be sister-in-law, works for me, and yesterday I was mentioning that I had to go to a meeting. I can't make another meeting today because I'll be at JPS with JPS. My sister-in-law had a terrible car accident that saved her life and made a difference in everybody in Stephenville and Carlton that they're connected to. You know, JPS is, everyone still speaks of JPS because of the mission she took.
Yeah.
So it's a small world.
Yeah, I think this is what differentiates JPS. It's really the heart of the individuals. That pink bow, that pillow that was signed, the surgeon who asked, can you pray? before we go into surgery. That is something very palpable here and special at JPS. And you won't see that anywhere else. And so I want to thank Miley and her family for allowing us to really share this story with you. We are really honored that they trusted us with this small part of her journey. I also personally want to thank the JPS team members, our regional partners who have been really a large part of her recovery and her care. And her story, as I said, is a strong reminder of the role that JPS plays in this region and why it is we fight so hard for JPS. With that, Mr. Chair, my report is complete.
Okay, thank you, Dr. Duncan. That was a great one. I appreciate that update. Glad to see the family doing well and how well she looks post-surgery and recovery. So we will move on here to item number 7. We've got Dr. Kirby here. This is a report from the medical executive staff requiring discussions, updates, deliberations, actions, and/or approval. And we have item A is to request approval of medical staff appointments and privileges. Dr. Kirby, thank you.
I may ask in the future to change my location in the agenda because this is the second time that Dr. Duncan has shown a touchy movie.
Yes.
All right, yes, as you requested, Mr. Chair, the first item is A, and this is the typical memo that I bring you in regard to medical staff appointments and privileges vetted by our executive committee. I will ask for an approval of that agenda item. Would you like me to do it separate from you or together?
Separate? Okay, that'd be fine. Got a first? Got a second? All in favor? Any opposed? Okay, item A is approved. So item B is the approval of Tarrant County Hospital District policies and/or plans, MS 4000 Medical Staff Bylaws 19411.
Thank you. So I am bringing you annual updates to our medical staff bylaws. We have a bylaws committee that works around the clock during the year to update our bylaws to reflect either our current practices or to put adjustments in place that reflect procedural changes or changes that mandate updates. These were presented to medical exec committee in November after being written by the bylaws committee and approved. It was then taken to the entire medical staff for a vote at our open meeting and was approved. And was since brought through the legal process to ensure that there were no changes that would be concerning legal respect. So that being said, this was sent to you in your packet, and I'd like to ask for a motion to approve the bylaw amendments as written.
Okay, I'd like to entertain that motion.
Dr. Kirby, if minor comment is needed next year,
I'm happy to read that.
and Dorothy told me she read every single word. So I think Dorothy.
Yes, she does.
All right, we got our first. Got our second. All in favor? Any opposed? Okay, thank you, Dr. Kirby. All right, we've got item 8 here. This is going to be committee reports and action. Demetria, where item A is the Finance Planning and Investment Committee from the June 25th meeting. I will let you give us that update, and I apologize for missing that one.
June 25th, 2026, our Finance Planning Investment Committee meeting. Our main net income totaled $6.9 million. We fell short of our budget by $1.8 million. Despite the monthly variance, year-to-date net income through May totaled $109.9 million, exceeding the budget by $25 million and reflecting our continued strong financial and operational performance. Our key performance drivers for the month included patient activity continued to reflect shifting utilization patterns. Inpatient volumes remained below plan, while observation cases exceeded plan, resulting in overall hospital utilization remaining relatively stable during the month. Patient service revenues exceeded budget by $208,000, primarily due to prior year adjustment that offset unfavorable payer and rate mix impacts. Supplemental medical funding exceeded the budget by $2.3 million and remained driven primarily by employee health claims, project-related expenditures, and increased pharmacy assistance program activity. The committee reviewed payer mix and key balance sheet ratios for the month. Commercial ACA continues to decline, while Medicaid, self-pay, and connection continue to increase, resulting in an unfavorable payer mix and lower reimbursement rates. The master facility plan financials and cash flow projections was reviewed. We have a total budget of $2.45 billion, total payments committed, total payments and committed is $954 million, and our budget remaining is $1.49 billion. The fiscal year 26 financial goals were reviewed with 7 of 12 metrics exceeding target. The committee approved May 2026 unaudited financial reports for advancement to the Board of Managers. And I also want to thank Jill, Kim, Brian, Ramon, and Alan, and Dustin was in the master facility plan meeting, and we kind of broke this down even more this morning, so it was a really great meeting. We had 13 contracts were presented and approved to proceed to the board for approval. Our fiscal year 2027 budget retreat 2 was provided by Kim. The fiscal year 2027 budget retreat presentation could resume from the previous meeting, beginning with a brief review of the budget development process, including a bottom-up approach driven by volume projections, followed by an overview of operating expense. Other expenses were reviewed with further discussion on revenue cycle, IT, sharing county programs, and correctional costs. Ad valorem, investment income, capital expense, MFP, cash flow, and balance sheet ratio trends were presented and discussed. Key budget assumptions and identified directional review with the acknowledgement that assumptions remain in draft form. The committee reviewed next steps, upcoming timeline, and sample documentation to comply with county budgets and policy requirements. And that is the end of my report.
Okay, thank you so much. If no further questions, we will move to item B, which is our governance committee on June 25th.
I just want to comment on
Yes, sir.
the meeting that Jill and Brian and Dr. Duncan scheduled for us to tour. It was really educational.
Great.
Really beneficial.
Wonderful. I appreciate that comment. With no further comments, we're going to move to item B, which is the governance committee. That was June 25th of 2026. David?
Yeah, I'll keep it short because most of this meeting is probably governance committee conversation. So, corporate compliance update, Colin reported 2 audit results on high-risk coding with 599 claims reviewed across other areas. There's also the access intelligence rollout that continues, which looks at household snooping detection, which went live in March 2026. On the enterprise risk management side, Daphne presented with FY26 top enterprise risks, access to care, IT infrastructure, facilities, capacity planning, along with industry-specific risks including talent attraction and retention, economic inflationary pressures, and AI adoption. One also notable item, the Epic ecosystem migration to Azure is on track for June 2026, and the AI governance work with outside consultants is progressing as well. Also, we talked about what we're going to talk about today, which is 1000, which is Daphne presented the amendments to the bylaws, which we will also discuss here, and then we were also going to talk about the corporate compliance program, but that was kicked until after the bylaw discussion.
Okay, thank you, sir. Appreciate that update. If there's no further comments or questions, we will move to item 9. All right, item 9 is going to be reports and updates not requiring board actions. Academic affairs update, Dr. Elliott.
Good afternoon. Good afternoon, everyone. Pardon. Sorry? Oh. I guess I could sing my report, Reverend. Not today, but thank you for that. I appreciate it. Thank you, everyone, for the opportunity again to bring our annual update for you for our annual review, institutional review, telling you a bit about what was happening in terms of academics and research Affairs here at JPS Health Network. Before I start, I always want to just mention that this takes a team. It's not just me up here presenting this. It really truly is a collaborative effort across our entire institution and entire organization to bring this forward to you and all that we do in terms of being an outstanding teaching institution and really doing this work in academics and research. So I want to thank, first and foremost, the core team in academic and research for all of the work that they do. My direct reports include Dr. Singer, Dr. Acosta, and Dr. Oja, and of course a team that reports there too for them. But it also takes all of my executive team members because we interface across the board, and of course I like to say all 7,200 of our team members are teachers because they really do help us to do this work in terms of our students and our residents and our fellows across the board and supporting all that we do. So, and thank you for the board for your support. So thank you for that personal privilege there. All right, we're going to give you a little bit of an overview of what we do here. Academic and Research Affairs encompasses several areas. We like to talk about the circle of life often, and that circle of life that we talk about is from July 1st to June 30th. That's our academic year, and that's when we welcome new residents and fellows and often other learners in here. And so you'll see that actually you've got some bright, starry-eyed people right now crossing and doing the care across our network. But it is a continuum of education, right? And so we start, of course, with those student experiences. So clinical experience is part of our academic affairs department, where we have nursing, pharmacy, and allied health students coming through, including our medical students also under the undergraduate medical education umbrella. And then, of course, graduate medical education encompasses our residents and our fellows. We'll talk a little bit about that specifically. And then we have continuing medical education because we are indeed lifelong learners, and we also want to support our faculty and our all of our folks doing that in terms of their lifelong learning and accrediting that, and that's done in partnership. Under that, we have our medical library. We have a partnership with UNT Health around that also to be able to provide medical library services. And that's actually 24/7. We have one of the top library opportunities there to help support the care that we provide. And of course, our research departments, our Office of Clinical Research and sponsored programs, and our Center for Epidemiology and Healthcare Delivery Research, which helps to also support implementation science, translational science research. And we also, of course, are very much believe in well-being. And so for clinician well-being across the board, we have a director of interprofessional well-being that works across the institution supporting that effort too. So moving on, just wanted to highlight some of our wins and some of the benefits there that we've seen. We've continued to maintain continued accreditation across all of our residency and fellowship programs. I'm pleased to say this is probably my 10th year of doing this, and it's great to see that we've been able to do that. I will give you a bit of extra kudos and excitement this year because we just wrapped up last academic year. Many of this, the things you see in your report were from our FY25 because we had to wait to wrap up FY26. But we have 0 citations across our entire institution, all programs, and that's a great. I know that's a great accomplishment, and I'm really, really proud of it, and really am proud of the work of our program directors, our chairs that support that, and all of our faculty and our residents for what they do. So 0 citations. We also have secured, continued to secure, and actually even increase some of our federal and state funding to sustain and expand our physician training capacity in these critical specialties. And this, of course, allows us to increase patient access and high-quality patient care. So we've seen GME funding in our emergency medicine, family medicine growth, psychiatry. We've grown that from not only the state level, but also through CMS and federal funding that way, increasing our CAP, our FTE slots with the indirect medical education and direct graduate medical education funds. Also, child and adolescent psychiatry has grown too, and obstetrics and gynecology. We've successfully filled 100% of our slots, continue to do that. We've also advanced research, scholarly activities, and our academic visibility nationally, and I'll talk a little bit about that. And then, of course, strengthening our healthcare workforce development through innovative initiatives such as our SHINE program, so you've seen even younger faces across the organization, and our Future Healthcare Heroes programs, but really making sure that we can start that awareness of what they can do in terms of healthcare careers here at JPS in doing that. And that's in partnership with our community partners. So just a few stats we like to present to you. So this is our incoming class, and so they're here now, of course, but this is our match data. We like to usually share and show a bit of those trends, just in terms of where they're coming from. So they are coming from mostly Texas schools, as you see there, but they also come from schools outside of Texas across the board. And so we continue to see that same trend happening each year. These are a list of our current programs and our residents that are with those programs. We've had a few shifts in changes in program leadership. There in emergency medicine, Dr. Jennifer Bird she stepped up from being the associate program director to now being the program director as of April 1st. We thank Dr. Huggins for all of his 3 years of service there in that role and continues to serve as faculty. We also have our other listed program directors there that really help to partner across the board to do this work across the board. But the good thing that you see in that far right column is that we have continued accreditation across all programs. And of note, when you see that approval without reporting requirements, that's just the way that CODA, which is the Commission on Dental Accreditation, that's the way they report their continued accreditation, meaning there's no need to report anything further. You are approved to continue with your accreditation. We also have some partners across our network here, across our DFW Metroplex here, and even beyond that, as you see there, where we welcome some of our residents who rotate with us here. And you see there with Baylor All Saints, the disciplines and the specialties that are represented there, along with our Baylor University Medical Center partners for the general surgery program, which helps us support our level 1 trauma designation there, and of course our other partners with UT Southwestern, ophthalmology, oral maxillofacial surgery, urology, and then some rotating residents from Medical City Fort Worth and Medical City Weatherford. And also we welcome U.S. Army and U.S. Navy with our military residents in these areas to also rotate here. I'll spend a little time here just in terms of our board pass rate. We've seen some shifts. Actually, I will just start nationally, in the board pass rates. We've seen nationally that many of our specialties have seen a slight decline over the last 5-6 years in the board pass rate. Normally, we would see 90 percentile ranges for board pass rate. We're now down in the low 80s across several of the specialties, including emergency medicine. They're doing some deep dive into what they think might be contributing to that, whether there was something around the COVID effect and the way learners learned and being able to apply some of that model of how you prepare for exams and things like that. So they are taking a deeper dive on the larger national front within medical education. But I will say for us, what we have done, we've really tried to strive for a 95 to 100% board pass rate, and we really take this seriously. So one of the things we have is a policy called a special review policy. It's something that the ACGME requires us to have, and we have a policy where we look at specific triggers or specific areas that may trigger in terms of a special review of a program. And one of those is an underperforming program in board pass. So we have actually conducted special reviews specifically for some of our programs that we saw this trend continuing. So we have conducted special reviews for emergency medicine, hospice and palliative medicine, and also for psychiatry over these last couple years to really see what those resources are needed, what is happening. I chair those special reviews along with having program director representation from a program that's outside of the program being reviewed. And we also have my staff that's involved, and we also have residents who also, our house staff leaders who can also provide us that input. And during those special reviews, we interview the program director, the program coordinator. We also interview the chairs of the department. We also will select certain faculty to make sure we're understanding what the resources, what the needs are, and their perspective on this, and also their residents at all levels to see. And that way we identify action plans, very specific action plans that the program must institute, that we do, and also what support is needed from the institutional level and the program level to support improvement in their board pass rate. So we have actually seen improvement, as you can see there, with psychiatry, where we've identified even things across many of these programs where we want to make sure curriculum is aligned to what we need in terms of mapping it, curriculum mapping to even understanding the blueprint of the board pass, the board examination, and understanding that we're making sure we're teaching appropriate didactics that are mapped to that. Also making sure we have faculty-led support in these areas and advisement around this. And really, I'd say it's also setting and re-emphasizing the expectation to our residents that we expect you to be board-certified physicians when you leave, and we're here to support you to do that. So with that being said, we've definitely seen an improvement. We're still awaiting emergency medicine's 2025, and then, of course, we just graduated the 2026 class, so it takes about a year plus. We probably will not see that until November. They take their boards in November of each year, and they're still awaiting that for the fall to give us that report. We have seen that just to give you also just a perspective when you see things, so like with podiatry, for the first time you've seen a 50%, that is a program of 2 graduates. So if one graduate fails when you have not seen that happen, that does give you a 50%. So it's just 1 of 2. Also with orthopedic surgery, they've had a 20-year 100% pass rate. This is really, truly, I think, just not consistent with a pattern that we see. But they've actually even already made some action planning around that in terms of board review resources. We've worked with Dr. Ming on what those needs are specifically, and really showing some improvement there too. And looking at their in-training exam scores to make sure we're identifying those residents that in need of additional support much earlier. And then also working with hospice and palliative medicine, we've actually boosted their board prep resources also and met with them. But they also have an interesting approach in that they don't necessarily have to take their board examinations subsequently after their fellowship to be credentialed to do that work. But we are seeing definitely more of the hospice and palliative medicine fellows hopefully wanting to take that board to make sure they're board certified. So we're doing active work with this, and I anticipate this will continue to go up and really meet our standards around board pass rates. Reverend Anderson.
Oh, that's the reason on hospice and palliative care, that's the reason they're going to take it.
Yes, they chose, there were no graduates chose to take it that year. It's an optional thing for them to be able to do that to further their credentials and to work in hospice and palliative. So that is at the American Board of Internal Medicine level for us to think about what that will look like. But we're encouraging them to take it because we feel like if you've done your fellowship, we want to encourage you and support you in taking that. So that's optional. Any other questions?
Do we have a requirement of being in-state? Because we understand that our, obviously, more Texas people.
In terms of the match or in terms of? No. We take them from all over. We have folks from all over the country, actually. Absolutely not. Absolutely not. But it is nice to be able to see, because what we do know about, I will just tell you this, what we do know is that if you do your undergraduate medical education in terms of medical school in the state, plus you also do your residency in that state, you're more likely to stay in that state to practice. It's about a 68% cumulative chance of you staying in that state. Okay. And so speaking of staying in the state and retention here, good. You'll see here where we have the resident location by their year. So last year we had 10% stay here at JPS of our graduates there, and about 75 plus graduates, and then in Tarrant County there too. So in the DFW overall, you saw about 30%. I do have some updated stats as of July 9th today, since we just said goodbye to our graduates of June 30th. And so I do have some updated stats for you that I can include, where we had 13% now staying at JPS, Tarrant County at 9%, DFW Metroplex at 13%. So that cumulative for the overall is 35%, with those staying in Texas, in those going out of Texas being at about now 48%. So that far blue line is actually less this year. More of them are staying in Texas, where we see 52% staying in Texas and 48% leaving Texas. So we're starting to see a shift back to remaining in Texas. And I will say, just to the point that you mentioned too, just about that, is that the ones that are staying in JPS, 55% of those are from a Texas school. So it is showing that trend that they are staying. Okay. So what are our priorities as we continue to do this work? We always want to stay continually ready, and we will do that and do the continual readiness activities, monitoring for all site visits, not only our accreditation visits, nothing announced at this time, but we always like to stay ready, and of course, Joint Commission readiness and anything else that arises that involves our area, we always want to make sure that we're contributing to that. We also want to establish opportunities for new GME programs and for GME expansion, looking for funding opportunities and ways to collaborate on that. We've talked about that here at this board, about programs that we're looking to grow, and so we're actively looking to see that and what that could look like, but also how we can fund that and what those opportunities are for expansion and aligned with, and we'll talk a bit more at the end about how we align that with our community needs and our service line needs. And we're putting in there now an institutional priorities to increase that overall board pass rate. We've added that here. And also how we can expand our pipeline programs and collaborations with our local schools, and also strengthen well-being initiatives, working collaboratively with our med staff leaders. Thank you, Dr. Assad, Dr. Peeler, and Dr. Palaciano for the work that they're doing also around well-being initiatives overall for all of our clinicians. So a little highlight here on our student experiences. We continue to really love welcoming our students here. We have active affiliations with over 115 institutions across 30 disciplines. So this is not only medical students, but nursing students, which we really welcome, because many of those nursing students also will decide to do a nurse residency with us. So we like to see that. And then pharmacy and allied health. So we have over 3,000 students, and also with those 3,000 students, that's about 4,400 rotations. So it's a pretty robust clinical experience, and I want to thank Dr. Chanley for her leadership there. One of our pipeline programs we started several years ago is the Future Healthcare Heroes program. That is our longitudinal program in partnership with Fort Worth ISD's Career and Technical Education program. That is expanded over the years. We started just with the PCT program doing EKG and phlebotomy, but now we've added the pharmacy technician program since 2025. That's in partnership with our CVS Health Workforce Initiatives Talent Center, the Whitsey Center, and Fort Worth Housing Solutions, and our JPS Vital One partners. And I want to thank Joy Parker and Stephen Schultz for their partnership there with us in doing that. We continue to watch that. That's important because we do know farm tech is a shortage area that we're trying to do. So starting that even earlier and having them have the ability to be trained and certified in that, starting even in high school, is a great effort for us to be able to be a part of. We also added emergency medical technician. We've seen more students wanting to have those experiences around EMT. And we have clinical rotations across these different areas listed. The current schools that are participating is O.D. Wyatt, Northside, and Young Men's Leadership Academy at this time. Our summer program is our SHINE program, Students in Healthcare for Individual Empowerment. We started that last year with the help of a workforce grant from the Office of the Governor, which we were very grateful to have. And as we started that program, we recognized that, wow, it was really competitive and there was a demand. For our 30 slots, we had 640 applications that over in just 1 month period. Yes, and these are only Tarrant County schools that are eligible, and age 16 to 18. So with that, we realized that we have something special here, and it's a paid internship where they spend 8 weeks with us, and they did a remarkable job last year. I think that really that first cohort, we like to say they were the pioneers really setting the bar, and we've continued to see great students here this year. And so with that being said, we were able to now expand that a bit this year and welcoming not only our SHINE interns, that those 30 high school students, and as you see, those applications continue to increase now with the popularity being spread out there. We also wanted to welcome some of our graduates from last year back and help them in their leadership development and really contribute to what we're doing. So they're back, and we call that the SHINE Fellows. And so those are 6 returning interns. There are now SHINE Fellows, and it's so great. I want to thank Dr. Chanley, Julie Vasquez, and Dr. Diana Singer for their leadership on that and their support on that, because they've made it really fun. I think everyone's taken someone under their wing. Dr. Singer's taken those Shine Fellows. They now have these Harry Potter houses of 6 houses where they lead their own teams of Shine interns, and they're doing just great things. And so it's fun to see them doing this work, but it's very impactful work because there's career readiness in there about that. How do you get ready for college and for your career, along with exposure to all of the healthcare fields across the board. And so these are our future leaders in healthcare workforce right here. We were also able to now start what's called Shine U. So Shine U is our university track, or it's our undergraduate track, actually. So you have to be at least 1 year into college so that you can be here and apply. And we had a lot of applications for that, too. And that's a 4-week experience. So we had 3 that were accepted in the first 4 weeks and 3 accepted in the latter 4 weeks of the time. That's also a paid internship that they're here. And many of them, I will tell you, we have future, I'm going to say we have future nurses. I think there's a CNO in there somewhere, Mr. Bose. And we've got future doctors in there across different specialties. We've got a future PA in there that came across. We have a future PTOT. So it's really impressive to see them. And the criteria for Shine U was that they either had to be in a Tarrant County school or have graduated from a Tarrant County high school before they come back. And then we also did a partnership there too with workforce, with our workforce partners there too, here in Tarrant County Workforce, to welcome 2 teacher externs. And these are our local teachers that want to kind of boost up some of those skills and also contribute to what we're doing and work with us. And they've been incredible in terms of just helping us with our simulations and our training and clinical skills building, and they've been great. So we've had 1 at a time over each 4-week period, and it's been really great.
What schools?
Pardon?
What schools are they representing?
I'll have to try to remember. I'll go back and remember which schools that they're from.
The 2 teacher externs, they volunteered or you recruited?
So it was in partnership that they actually apply to the Tarrant County Workforce group, and they basically apply to be considered, and they are in different fields, and we happen to be one of the healthcare fields. So they can be teachers that are across different disciplines, but we were welcoming those that were interested in healthcare or teaching healthcare in some capacity in their schools.
So then that has potential to grow then?
It does. It does. Yes. And they're supported by the workforce solutions. So, and then also I cannot, I'd be remiss if I did not just thank also our foundation for their partnership with us. And not only have we, as JPS, thank you, Dr. Duncan, for the support that we have to continue this program, because we did not receive the workforce grant the 2nd year, but we have invested in that from a JPS perspective, and also had our philanthropic partners with the Sid Richardson Foundation, the Amon Carter Foundation. We've had Bank of America and Rainwater, and all of them contribute to support, and we're going to hopefully continue that support. So, yeah, so please spread the word. Shine is working. All right, I'm going to go into research a bit, just briefly here too. I want to thank Dr. Acosta again and Dr. Ozier for their leadership and the team that works across the board to support all of our departments in research and innovation and scholarship and grants. And you can see that we continue to be robust in our abstract submissions, our scholarly activities, and our poster presentations, and supporting them to do that. Dissemination of scholarship is a requirement. It's part of what we need to do in teaching institutions. You need to do that in terms of presenting them at conferences in different areas, but we also, of course, support them presenting at our own research and quality symposium too. And so you've seen that growth there in terms of publications also. We continue to see that in scholarly activities. Yes?
What's the general acceptance rate for abstract?
You know, it's hard to know, because some of those we don't necessarily see when they submit it, so we don't track. We just track the acceptance. Once it's accepted, we ask them to report, and we send out a quarterly request to all of our faculty and residents across the board from my office to say, please let us know. Plus, our medical library team also does a nice scouring out there to make sure we see things that are attributed to any of our faculty. Yeah.
Dr. Elliott, are these submissions or acceptances?
So those are submissions and likely also acceptances too, that they've done a great job, yeah. Because that's reported, yeah. All right. clinical trials also has grown significantly. As we've built the foundation there in research and what we've been able to do, it has been great to be able to see the growth in clinical trials. And as you see there, we've seen it across the board in different areas in the organization, particularly growth in oncology. We've also seen growth across the board in internal medicine, in terms of orthopedics, podiatry, surgery and trauma. We have some in family medicine and women's health, and of course in behavioral health also. So we continue to work very well and collaboratively across the departments to continue to see how we can improve our clinical trials, because it provides access for our patients, and we want to continue to do that. And then, of course, working in terms of grants, and our grant portfolio has grown over the years. We have centralized our grants process into our Office of Clinical Research and Sponsored Programs, and really work very intentionally to try to really look at those opportunities out there. This year, we're keeping an eye on this in terms of FY26. As we know, there's been a dip in terms of some of the grant opportunities that are out there, just in terms of shifts in funding and policy, but we'll continue to always be able to go forth and try to look for those that align with the needs of our patients. So this is just a summary, just to say we are transforming healthcare delivery for the communities we serve, and research is a part of that. So to see that number really is very, very exciting to be able to see that we're benefiting over 31,000 patients just from grant-funded programs and clinical research supported by this funding. So we've expanded access in women's health, as you see across the board there. Also in cancer care, as I've mentioned. Also clinical trials has grown, and we've had over 2,100 patients participate in these active clinical trials, and we'll continue to grow that. And then, of course, chronic disease, behavioral health, and prevention. One of the pearls I'll say, we have a grant now called the PATH grant that is around eliminating Hep C. And we are the only Texas hospital that has this, an institution that was awarded this grant. And it really is understanding that Hep C is a treatable disease, and we want to be able to support our patients to be able towards cure. So we've just started that and working collaboratively with many of our partners from the emergency department there. Thank you, Dr. Kirby, across the community health, across our research and all aspects, our lab services. Everyone's been very much involved in doing this and providing this care so that it can be very low barrier access to this care. And we're pleased to report we've already seen our second cure. And so just a short period of time. So it's really exciting to see that. And also, we want to make sure, is the care that we are providing, that we're doing for our patients, is that also effective? We want to make sure we can improve that and that we can improve processes that are in place. So we work very closely across the board with our teams across the board to evaluate that, and Dr. Oja's team does that. And if there's a question that comes around any kind of evidence-based practice or healthcare delivery models or evaluating that, we do that. So one of the things, these are a few examples of some ways that we've impacted that. For instance, just looking at our effectiveness of care transition programs for our JPS Connect patients, discharged to skilled nursing facilities, and that in being able to look at that and actually putting these programs, we actually evaluated our programs, and I want to thank our nursing team, Cheryl Berry. I want to also thank Jill Farrell and Dr. Assad and Devin Armstrong for the work on that. But the work that they have done in their care transition program has been shown to be very effective to reduce hospital readmissions by 2%. And then also looking at our Epic no-show prediction tool, we wanted to kind of see, could this be a tool that we could use to decrease our no-show rates? And so we've looked at that, and so right now interventions are being pilot tested in clinics to see if we can help patients keep at appointments and adhere to appointments. And also tested a text message outreach strategy for over 700 self-pay patients, just to enhance that enrollment in healthcare coverage. Oftentimes what we saw is that patients don't even necessarily realize they may be eligible to enroll for additional healthcare coverage. And doing this text message outreach strategy that we also evaluated showed an increase in 7% of them enrolling. And these were all enrolling in, this wasn't enrolling in JPS Connect, this was actually enrolling in other healthcare coverage options from Medicaid to third-party payer.
So I think this is great work and really using research and integrating it through all the work that we do across the organization. So thank you so much for.
Thank you, Dr. Duncan. All right, so we're going to shift gears a bit, and thank you. Just going to pause here if there were any questions from the overall review. All right, I think what we'd like to do is shift gears because we've had some multiple conversations just in terms of where we want to go in terms of academic and research. And I know we're right now very actively engaged in strategic planning. And I do think that academic and research is part of that strategic growth and that strategic planning. And in that time, we've talked about a little bit, are there opportunities around academic partnerships to consider? How do we actually be strategic around our growth? And how we actually do our work in graduate medical education and also the work that we do in research, but particularly how do we align what we're doing in that area. And so we know there's a need for growth, and so we are moving ahead with a consultant that will be helping us kind of look at what the workforce needs are, what are those not only those physician workforce needs and those community-based needs, and we'll talk a little bit about how we're going to approach that and what the things may come up in that. So just to talk a little bit about academic partnerships, it truly can be a formal collaboration, but it can look very different depending on what we identify as our goal. So a teaching institution like ourselves, a teaching hospital like ourselves, partnering with an academic institution can help us to link more in terms of advancing more clinical care, education, and research. And our overall goal, of course, is to enhance the training and the innovation and of course, our patient outcomes. So as we're evolving our healthcare landscape, we have an opportunity now to really strengthen our mission through collaboration, and that's what we want to truly evaluate very thoughtfully. One of that, of course, is also to make sure we're providing high-quality patient care to meet the unique needs of our community and to foster innovation in medical education and research. So we have built a very strong academic and research foundation. I'm very proud of what we've been able to do together to do this. And so next, we just want to see how we can align our academic partnerships, our clinical growth, and our workforce needs and our community impact into one coordinated long-term strategy. So part of doing so is really thinking about our current partnerships and potential other partnerships as we are being approached by maybe others or we seeking others to be able to partner with. And so how do we strengthen partnerships and deepen and establish those affiliations that can really help us to advance our mission? So understanding what our priorities are around access, is it around workforce, is it around all these other areas that we've identified? And then how can we align our education on training programs directly to our JPS clinical priorities and service line needs? So that's going to be important to really evaluate what that looks like, projecting that over the next 3 to 5 years and more and beyond. And then what do we need to have in place? Maybe what we currently do have in place, or what do we need to add to be able to develop our workforce, to support our physician and health workforce pipelines for our region, and to build new GME programs. And then expanding our impact. So we want to grow that research and our community engagement capacity, but also what's the infrastructure that's needed that we need to invest in to be able to actually build an academic infrastructure, and what is the governance around that too in terms of partnerships if we do. And we'll need some direction and assistance to be able to provide that. So if we are thinking about academic partnerships, why would we even consider that now? Well, I mentioned to you that we've actually established a really robust, wonderful academic and research foundation, but there are still limitations to how far you can go with that. So we have regional clinical demands and workforce needs that are truly accelerating that we've talked about here at the board. And our training capacity requires us to really be intentional and more forward-looking about what the needs are. And that our academic programs really need to anticipate what our service line needs are and what our patient needs are and our community needs are as we're growing. And what are those specialty needs that we need. And I also mentioned to you why now, too, in terms of the research capacity, too, is that we are limited. And so in partnership, it might allow us greater access to some of these grants and some of these other research opportunities that may be there. Why JPS now? Why are we a great partner? Yeah, we're a great partner because we're very mission-centered and we provide excellent care for our communities. And so being a public safety net mission with deep community trust makes us attractive, I think, to an academic partner. But we also have very well-established graduate medical education that's nationally recognized also, and we have a broad clinical learning environment across different specialties. We have a strong existing platform that could be built upon and expanded. And why an academic partner? Because it will allow an expansion of our educational capacity and a shared workforce development model, where we can look at that. We'll have to, of course, see what are those different structures out there for governance of such those types of workforce development models. And as I mentioned, opportunities for with an academic partner for research, innovation, grant and funding opportunities, and a mutually stronger academic identity and institutional infrastructure. And this just tells that more of that. Academic partnership benefits and considerations. So the training alignment, the potential benefits where we can better match programs to our community and clinical needs, really looking at our talent pipeline to be more competitive even for recruiting and retaining physicians, faculty, researchers that really would want to come because they have that grounding, not only the experience here being at JPS, but also that academic component too. Also growing our research in terms of expanding our grants, our clinical trials. It'll give us more capacity in that sense, and also be mutually beneficial in terms of stronger reputation, building upon our reputation that we have nationally, and whatever academic partner, their also academic identity and regional impact. So it could be mutually beneficial for both. The key considerations are outlined there on the right, where we want to ensure that there's mission alignment. We know who we are as JPS and how we are committed to serving our communities and those values that we possess. We also will need to be looking at what that governance structure can look like in terms of decision-making and accountability. Financial sustainability, it will require investment on all sides, and so we have to assess what that long-term investment and cost structure can look like on both sides. And then, of course, some operational complexity, just making sure that we can manage the workforce staffing models and integration and really build a phased integrated approach and accountability model around that. Specifically on the GME growth and alignment, as I mentioned, we definitely see the signals happening here that there is a need for growth, and there's a need for expanding our training focus and our specialty focus also. So the strategic questions that we need answered that we will be working with our consultant with are, how should JPS assess, how should we grow, and how should we develop our GME program portfolio? Looking at our current portfolio, the distribution of that in terms of funding, and saying, do we have the right slots? Do we have the right things? Or do we need to, if we do, where do we need to grow? What are we missing? And what do we need to add to our GME program portfolio? Clinical alignment, how should we actually align with service line needs and community health needs? And how do we need to do that in terms of building specialties and building those GME programs? Workforce planning. What are those future physician workforce gaps? How can we be proactive in that and addressing that through our educational programs? And then we also want to be able to know what are those different types of partnership structures and partnership models out there that can best support our mission, best support our values, our autonomy, and our long-term goals, and what's the model in terms of the infrastructure, in terms of operationally and financially that's needed to support meaningful GME growth. So we are engaging a consultant, Manat. We have identified, we're finalizing that agreement right now with, as we did an RFP to be able to do this and identify our consultant to really help us do this work. And these are those focus areas just kind of outlined again here. They'll be assessing our academic partnership options and structural models, of course, evaluating our GME growth, alignment, and portfolio, strategy around this, and building our strategy around this, review operational and financial infrastructure needs to support GME growth and research academic growth, and also identify those governance models to support academic and research growth and develop strategic recommendations for sustainable implementation. So our next steps, we're going to launch engagement actually very soon. Where we're initiating that kickoff there to really kind of look at the scope of the work and build that project scope and stakeholder alignment. We're hoping to have review of the different models, assess our current partnership structures and future potential partnership structures and strategic options around that, and our program needs around this, align our priorities in terms of how do we integrate clinical workforce research and community goals. And we'll figure out the cadence. We'd like to hear, and we'll work with you on the cadence of how we want to bring this back in terms of updates to the board from once we have the findings here. We hope that this will be conducted over a 4 to 6 month time period. We're trying to get this information here fairly quickly. I think that's a lot of data that will be needed, but we are definitely excited about having this. We haven't had an overall review again since about 10 years, and Mr. Bose knows this, and that was probably one of the times that I was recruited here myself, so glad to be here, and so glad to see this next phase as we've grown significantly over the last 10 years. And I appreciate your time, and I welcome any questions.
So I would like to thank Dr. Elliott. Dorothy, as you remember when you were chair, and I kind of brought this forward as I was stepping into this role, and really felt that we needed to really consider and look at an opportunity for a possible academic partnership and what that could possibly look like, but really in order to kind of begin growth within our GME program and our research. And wanted to, we've done quite a bit of work. Dr. Elliott and I have had multiple meetings with different academic organizations here in Texas. They are very impressed with the work that we do, feel that it's real fertile ground for a partnership. Again, what that would look like, we're not sure. But want to thank Dr. Elliott for taking the lead on a lot of this and representing JPS well. So we will continue to bring it back to the board, but we continue to work through that.
Thank you very much. Appreciate the support.
Thank you, Dr. Elliott. Okay, well, this was a pretty exciting update, so we look forward to hearing more, and we appreciate those updates, and it's a major step as we consider these options out there, so I appreciate that update. So on to item 10 is to consider matters requiring board actions and/or approval. We do not have any items today. So then we will move on to item number 11, which is the consent agenda. I've got, yes.
On this, I would appreciate if we can hold the governance committee so pull back from
Okay.
the rest of the items.
Yes, sir.
I'd have to go in closed session as well on that one before we have a formal conversation. And then I'd also like to pull item number B as well for the rest of this.
Okay. So our consent agenda items, there's been a recommendation to pull item D, and that's under finance. And then we've got governance item number 1. With
Mr. Chair, I also wanted to pull item B from consent, maybe we could do it, but I wanted to comment on item G, not to pull it from consent, but I wanted to comment before we vote on consent.
Yes, sir. So you would like to comment on it prior to the vote, is what I'm understanding? Okay, understood. Okay, any other thoughts or comments prior to the vote? All right, with that, I'd like to entertain a motion. That's with item D under finance and item 1 under governance being removed, with item G being discussed prior to the vote. I guess this is you now, Blake.
So G, this is an exciting time for JPS. G is the lease of 4 Da Vinci 5 robots. The cost you see there, $20,454,000 is the expected cost over 7 years. This is the top of the line robot that Intuitive makes, and this will, I think, make JPS the only hospital in Tarrant County with a 100% Da Vinci 5 fleet for our surgeons. This process has taken a bit over a year, and I want to thank Kim and her team in finance, and Dr. Ward, Dr. Tosca, and their team in surgery that work so well together to go through all the complicated lease issues and develop this contract that we're voting on today. And they work very well together. It's an excellent job. But this will definitely bring our robotic abilities of JPS to the cutting edge. So it's very exciting. Those are my comments.
Okay, thank you, Blake.
We love your excitement. We're going to get you excited for some other things too, but thank you.
I think Dr. Moore's ready to remove my gallbladder just to test out.
Okay, with that, appreciate that, your comments there, Blake. With that, I'd like to entertain a motion.
We'll go on the consent agenda, except for D on the finance and under governance.
All right, thank you, Dorothy. I've got a first. Got my second. All in favor? Any opposed? Okay, the motion carries. Okay, do we want to take a few minute recess before closed session?
D, we can
I'm sorry.
discuss D.
Or, item D. Okay.
Yeah, so, item D, one, I always catches my eye when there's an exception to, obviously that. But second, I would like an understanding of, this is my word, so, of what the terms advisory, liaison, and regulatory agency support actually mean, and why the skill set is so specialized in this firm that you wouldn't do this.
Absolutely. So Mike Spivey has been involved with the LPPF program in Texas since it was born. And so he's been very, very active in this program. Across, at one point in time, he did all the hospitals. And when that coalition broke up, he actually went to serve JPS only around the LPPF. Just so the local provider participation fund, we serve 39 hospitals in the county in Tarrant County. Mike's advisory services span beyond that. He also works with us on the Medicaid supplemental programs, and he is based in Washington, so he stays very close to what's going on in the federal level, relative not only the federal, but also the state of, anything that impacts the state of Texas. So one of the reasons his contract is up in September. The LPPF itself is up for session in January of 27. The program itself expires at the end of 27, and so we want to at least retain his services to understand where this program is going in the state of Texas. He also does some modeling for us if we need extreme modeling.
Yeah, I understand, and I'm generally okay with this. I know there are folks that generally know certain subjects a lot better, and LPPF is probably, there's only a handful of folks that would even understand the baseline of it. At some point, I don't like exceptions in this space. I just don't. There are others out there that I think can participate. I'm okay with it. I'm not one to shock the system, especially before session. Like, I don't think that that's necessarily wise, but I also don't like 5-year agreements on promoted vehicles, especially for a federal consultants. And so, I think in conjunction with the position that you have posted, health policy position posted, it probably would be good to look at the entire shop when it comes to these type of matters to begin with. Because there will be some things that have to be out-house, and then some things that, probably won't be in-house. And so I don't know if I'm super comfortable on a 5-year on this. I think, I think we can get through session, in a year or two, and get that done. I don't know, and I'm just, this is more my ideology, speaking to my understanding of the exact contract and what they do, but that's just kind of my struggle.
Right, and
What are
so-
you comfortable with as far as years? Just because it takes us some time to get these RFPs up, and, get them through the process. Are you with a 3, 2?
Session, so I 18 months to 2 years probably, so that way you can get through the session, get the modeling done, and then by that point, I think you'll have a position, here where you can look at your total apparatus around it, and that might naturally fall into that conversation and building up that goal for that point.
So would it be a 2-year with a 1-year extension in case we run into?
Yeah, that's fine.
Yeah,
I don't
okay.
mind having extensions capable. I just, it's, this, I come from this world, and I know, especially no bid, and I get, that there is specialized experience. I don't want to discredit that. I just know that there's a lot of very smart people in this world.
I appreciate your concern. We also know that there's a 30-day out on this, so that if we come to be able to need to terminate or want to terminate early, we can.
Yeah, so I would hope that we can move forward with it, but with a look at once, staffing is taken care of, we look at the total policy shop and how it, the resources that it's allocated to address issues like this and Medicaid, okay, came out on the words in your mouth, so do you wanna say what we talked about to be acceptable?
I actually agree with David. I mean, we had talked about anywhere from 1 to 2 year agreement. I'd like to get through session and the modeling, and that's the range we were discussing.
Right, we were talking about maybe 15 months to get to the end of 2027, is that acceptable?
The issue will be is the modeling, is because that will be right at the end and it'll start the new programming. So we really want to go past that a little bit, yes.
So you wanna look, how long, 18 months?
I appreciate David's 2 years with 1 year extension, knowing that we're gonna look at the whole shop. I think that would be the best for us.
We do have a 30-day out.
If we're doing 2 years, so 1 year extension would not come back on the board. I think 2 years.
So that would just be a 2 year. We would just do a 2 year. That's acceptable. That's fine.
And then that way, again, future state.
Yep.
Yes.
It's always gonna be complex, but I just, the exemptions from it just need to be.
Appreciate
right.
that.
Okay, I appreciate that, David. The governance item, no further discussion on that, is that correct?
I would like to go to closed session.
Okay,
first,
understood.
and then-
So with that, I'd like to entertain a motion on item D, please.
I'll make the motion since I'm being difficult. I approve a slight modification. I approve a 2-year contract, or a motion to approve a 2-year contract with the requisite amount that prorates to that. For item.
Okay, thank you, David. If I could get a second. All in favor? Any opposed? Okay, I appreciate that. That carries. So we will, how about a 5-minute break here as we go into closed session? Okay, it's now 3:15. I'd like to leave closed session and reopen the meeting. And we've got one item that we'll take action on, and I will turn that over to our governance chairman, David.
Okay, I would like to, there will be kind of two folds to this. I would like to ask for approval of the Tarrant County hospital policies or plans, the bylaws of Tarrant County, with the caveat that we table the discussion on the reporting relationships between the CLO, the CC, and the CCO until next meeting, so I can work with Daphne to draft the language, to draft additional language around the
So we're approving only
We're gonna approve everything else.
Okay, that rolled up.
Except for this one section.
Got it.
We will bring back to the August meeting with additional language that we'll work on.
Okay. And that was outside of the red line that we presented.
And do we need to address regardless of attendance if there's a quorum in this or no? Okay.
I'll second.
All in favor? Any opposed? Motion carries. Our next item? Okay, so we're good. Okay, I got you. Okay, all right. Any other further comments or
I
concerns?
just have a question on comments before the board, public comments.
Yes, sir.
Is there a time where a discussion can take place in reference to that as a board? I mean, they come in comments and we sit by and did,
Right.
but we just let it sit. We don't do anything about it, or say anything. I'm not saying anything why they made the comment.
That's right.
In the meeting later or something.
Okay, Reverend?
I think what you can do, if you feel that there is something that we could respond to, you could ask that we take it back and come up with a response and bring it forward to the board. You know, we have given updates in quality regarding the jail care. So unless it's just discussion about comments.
Can we have maybe the best way to do would be, can we have a discussion on the best practices in jail care as it relates to the interlocal agreements? Because that's essentially what they're trying to do. And we don't have to have that as a full board by any stretch, I think. That would be the conversation that I think would be, if the ILA is gonna come back to us in September, maybe it can even be a presentation on the ILA and, what's working, what's not working, and just like, that might save that.
And it really doesn't term in September. There were renewal options, so we'd have to decide. I mean, it has a 3-year extension on it.
Also, it's just a 3-year out, so we don't have to renew it in September.
No, we don't. That was just the initial
Just an
term.
annual update on.
Yeah, I mean, yeah, we can do that. I mean, Dorothy, I'll let you speak, because you and I've had some conversation. Again, it's the sheriff's office that oversees the jail, and we contract with the jail for part of that, that is provided there. And so, again, I want us to be mindful of the role and responsibility of each within it, and not have us get into what is the responsibility of the sheriff's office to oversee. And I think sometimes there is that confusion that goes on there.
A lot of the stuff they were
Yeah,
asking for is that.
yeah. So I want to be respectful, because I would not want for somebody to kind of come into my house if I'm overseeing and responsible for something, and then come up with an agreement that would somehow make it difficult for me to oversee and be responsible for that. So,
But I do think what is the routine standard of care for jail is something that we probably need to look at, to be aware of. We are a healthcare system, and we provide services the same way. We try to keep the same level. And I don't think that jail care can be looked at that way. It's the standards that they set up for jails, and we are a healthcare system, and I'm not sure our standards, I think our standards are higher than those. I think they need to get a company that provides that service.
that group comes to the board. Actually, I wasn't really talking specifically about jail care, but I thought
Just
I
in
was
general.
bringing that up there. But they come to the board, but also they in my ear, the jail is in my ear outside of the board. Okay? And I get a lot back and forth, and so we go back and forth. And I think that our discussion at the board, based on what Dorothy shared, when we have that discussion, then they hear us and understand what our position is on jail care.
I don't think they understand that you're just in one little area. And since Blake, when he didn't bother the sheriff before he talked about it, the hospital staff does not decide who gets to be sent to the sheriff's department.
Yeah,
So
right.
you're just in an area, so sometimes when they talk, they act like we were going and making rounds like we in the hospital. That don't happen. So the sheriff or the deputies make all the decisions who come to be sent. Not us, and so we can only see the ones that they bring to us, which is totally different than what hospitals know.
Because he can paint a good picture, but that's not what the situation is, and that's what my concern is.
Yeah, I heard this and they'll say the hospital, and I said, but we're just in one little isolated area. We don't identify who's sick, they identify who's sick. They bring it up to us. We don't go and make rounds and say this would need to be seen. And I think there's a misunderstanding of what we can actually do there.
I mean, I think that they're discussing what the public speakers brought forward to the board. You can talk about what you'd like from staff to see in relation to that. Mr. Chairman, if you'd
Yep.
like to take it offline, we can.
Any further discussions? Okay. All right, thank you, Reverend. 3:25, meeting's adjourned, thank you.